Oh no. I'm Maggie. Nice to meet you.
Thanks for
How do you
having
pronounce?
me.
Yeah, how do you pronounce your last name? 'Cause I probably just said it wrong.
Mikhail.
Mikhail. Okay, cool. Thanks for joining us today. We'll wait for
Oh yeah.
people. I've definitely done that same thing before.
Oh yeah. I normally am like very on top of it, but I was like I think I because I put it in my own calendar and that was the
Yeah,
only
like
thing I
as a
saw, I was like,
placeholder.
yeah, I was like, oh, makes sense. Maybe I should pull this up and see if it just pulls up on my own. So let me see if I can share content here. And is that working?
Yes.
If I go into presenter mode, does it work?
Yeah, looks
Okay,
great.
perfect.
And we'll wait a little. The OB/GYN department has like the M&M that we do, and it's actually in person. So then everyone transitions to
Got it.
virtual. So it takes
Okay.
a moment.
No worries at all.
Yeah. Morning, everyone. We'll wait 2 more minutes at 8:05 will start.
Hi, Dr. Ling. Cashel is using her username to log in for the residents today.
Oh, okay.
Yeah, thank you.
Are they already logged in then? Yeah,
They are doctor,
I
yes.
see at the bottom. Okay, that's good to know. Okay, we'll get 1 more minute then. Okay, we can start the intro then. Okay, Dr. Mikhail, I'm going to start if that's okay with you with your intro.
Yeah, please.
Okay, all right, because the residents are logged in together in a room. So, all right. So I am subbing in for Dr. Taylor to host Grand Rounds today, and I'm really happy to introduce our speaker today, Dr. Christopher Mikhail. He's an assistant professor in the Department of Orthopedic Surgery at Cedars-Sinai Medical Center and currently serves as the Director of Spine Education for the Orthopedic Residency. His current clinical practice focuses primarily on motion preservation spine surgery and optimizing spinal alignment. This focus currently is on performing surgeries for complex deformity from chin on chest to scoliosis and kyphosis, while also performing disc replacement and minimally invasive decompression. In addition to his clinical practice, he currently serves as the Director of Spine Education for the Orthopedic Residency and clinical instructor for the Spine Fellowship here at Cedars. He has a passion for research and actively publishes ongoing research in peer-reviewed journals such as Orthopedic and Neurosurgery. And he completed his residency at Mount Sinai Hospital and then fellowship combined orthopedic and neurosurgical spine at OCH Spine or Ox Spine at New York Presbyterian at Columbia University and Cornell. And at that time, he served as assistant attending physician at both of those institutions. Um, and we're very happy to host him today and learn a little bit more about spine health. Thanks for joining us.
Thanks so much for having me. I'm excited to give this talk. Yeah, I know that's a mouthful. Essentially, like most other spine surgeons here, we have a pretty combined group of people, both neurosurgery and ortho, and we're one of the few centers in the country that are kind of trying to lead the path on kind of joining forces because I think there's a lot of benefit to having both teams involved. We have a lot of us have very similar backgrounds. Like, for example, two of the neurosurgeons have the exact same fellowship as mine. So it's kind of an interesting way to look at it. But we all kind of do a lot of the same things. But my focus is really going to be mostly on cervical, complex cervical cases, cervical disc replacement, and infection related things. All right, so I did change the topic a little bit because the first topic didn't seem really appropriate for this audience. It was kind of a more boring topic, and it was very broad. So I'm trying to focus more on women's spine health specifically. So I hope that that's okay. So I have no disclosures. And we're just going to go over three major points here. Common spinal conditions in young women, spine health during pregnancy, and menopause's effect on spine health or postmenopausal spine health. So the first one is a really common condition we see in up to 8% of the population. This happens primarily in young women, and I put this picture up of a gymnast clearly showing how hyper flexible she is. You can see that she has a lot of extension in her lumbar spine, and this is one of the most high risk factors for developing this condition, which is spondylolysis. We use a lot of words that sound very similar because they're the Latin word for spine. But spondylolysis is specifically referring to a fracture of an area of the vertebral column, specifically an area called the pars intraarticularis, which is where that red line is. It's essentially splitting the joints. There's a joint above and a joint below, and it splits them off of each other, and that allows the disc to slip forward, especially when it happens bilaterally on both the right and the left. Oddly enough, this does happen in up to 8% of the population. We are absolutely not offering surgery for 8% of the population. What we find actually is a lot of these patients will have some sort of story or a background in sports where they do a lot of jumping or hyper flexibility, and they will complain of back pain maybe when they're older, sometimes like 50, 60 years old, and we'll find that they have this fracture, pars, and a slip disc, and we almost always will attribute it to something that likely happened when they were younger. And oftentimes patients will have a story, and sometimes they actually have no story. They're like, I have no idea how this happened. So there may be some congenital anomaly involved as well with some of these. But this is something that we really commonly see as well. It's kind of a continuum of that. This is a spondylolisthesis, listhesis meaning slipping of the disc. And I think slipping disc is actually kind of a funny term because it's clearly not a slipping disc, but it's a slipping vertebral body. So this is a picture of one of my partners, Dr. Skaggs. He does pediatric orthopedics here, and he primarily focuses on this, actually, slip discs. And you can see here, this is a fracture of the pars that resulted in a slip disc. And you can see that this is a really high grade slip. I mean, this girl's L5 vertebral body is almost entirely slipped off of her sacrum. She was also a gymnast. And this is what we call an in situ fusion, where he clearly brought it kind of back, but didn't really fully reduce it back to where it should be. And there's some benefits to that, but also long-term consequences that are not fully well understood in the pediatric population. As an adult spine surgeon, we do see a lot of these patients come back for more surgery because their alignment is not necessarily optimized with this type of surgery. But the benefit of this surgery is that you are less likely to encounter any neurologic deficits like foot drops and things like that, because when a bone is slipped this far away, it usually is pushing so far on the nerves that any manipulation or pulling back of the bone could cause that nerve to be irritated enough to cause malfunction of that nerve. So this is technically a safer neurologic procedure, but sometimes results in problems down the line. This girl actually went on to going back to complete sport. She's an active gymnast now, which is pretty amazing to see. The other really common thing we see in young women is idiopathic scoliosis. Idiopathic scoliosis is the most common form of scoliosis. There are many types like congenital scoliosis, neuromuscular scoliosis, but idiopathic scoliosis is something that we don't really have a good grasp on why it occurs. There must be some genetic component to it, but I think it's just so multifactorial that there's not a specific gene that we've ever been able to fully target. However, if you look at the data around scoliosis, the rate of which it occurs, mild scoliosis occurs, which is a curve of less than 20 degrees. It most likely affects the thoracic spine more than the rest. And if you look at curves less than 20 degrees, mild curves that don't require any intervention really, they occur more frequently in women, 1.4 to 1 ratio to men, but which is not that remarkable. But when you look at severe scoliosis, curves greater than 45 degrees, and that's stuff that requires surgical intervention, that actually occurs in women at 7 times to 1. So it's actually quite rare to see a young boy or later in life men needing surgery for scoliosis, specifically idiopathic scoliosis, but it's actually very common. Like if you look at like Dr. Skaggs's practice, I think it's like 80% of his patients are women or young women, and it's because of this rate of severe scoliosis primarily affecting women. This is also important because this does have some predispositions for a couple things. Scoliosis is does cause some predisposition for osteoporosis. The link is not well understood, but I do think that we're not really sure as to where it happens or why it happens, but they do find that there might be worse bone mineral density in younger populations with scoliosis, which we'll talk about a little bit later. In terms of treatment, bracing, the reason why I have a big X over those braces on those clearly adult women is that bracing is really only used in the adolescent growing population. So it's primarily designed to minimize curve progression in patients who are still actively growing, so skeletally immature patients. As soon as a patient is near skeletal maturity, meaning for most girls, you're talking about 14 years old, past that, the benefit of the brace is pretty much zero. And even in growing children, the brace is really only used for curves that we think may progress during that growth period, because curves tend to progress much faster during growth. So you may have an 8 or 9-year-old girl. She has a 20-degree curve, and we're worried that by the time she's 14, she's going to have a curve in the 45 to 50-degree range, and therefore we'll put them in a brace. And bracing is really not well tolerated. There's a ton of studies on this. Originally, braces were designed to be on 24/7 with very few breaks, and then they found some sort of threshold number. They asked girls to wear it about 18 hours a day, which is pretty much all the time. And that had really, really poor compliance. And then some people have pushed it down to 12 hours, which has better compliance, but equally abysmal results, considering that you're still not wearing it long enough to affect that curve progression. And there are some negative side effects of the bracing, which is primarily emotional. If you put somebody in a brace during their adolescence, one, they don't want to wear it. They don't want to wear it to school. But sometimes it's embarrassing, it's bulky, it's hot and uncomfortable. And then at the end of it all, if they fail, of which there's a reasonable high failure rate, and they end up needing surgery anyway, that really ends up taking a toll on them mentally. So they're pretty upset that they had to wear a brace and then they still didn't avoid the surgery. Finally, in the adult population, physical therapy and surgery are by far and away the two most important parts of this. Physical therapy is something we use kind of endlessly. There's a specific type of physical therapy that's, again, primarily used to prevent curve progression in young patients, but I found it to be pretty helpful for older patients. And that's something called Schroth physical therapy. Schroth physical therapy is designed to bend against your curve patterns and types to hopefully kind of work on straightening your spine and strengthening muscles opposite your concavities. So you essentially are trying to balance out the muscular forces across the the curves. And that's proven to be quite helpful for symptom relief. Having really good core strength is also incredibly important. I usually see some women who have some of the worst curves I've seen who have no symptoms are almost always the most physically fit people. So I always tell people to be as in good shape as possible because it'll make them a lot less symptomatic. Surgery is reserved primarily for people who have symptoms, and that number one symptom of scoliosis is, of course, back pain, primarily over their deformed areas, which is, they'll have rib humps or prominences because of the rotational component of scoliosis, or pelvic obliquity. So those things we can try to correct for them if it's something that really gets in the way of their life. So this is an example of what the natural progression of scoliosis. This is a paper that we use that's ridiculously old. It's from 1983. It's what we like. It's like the Bible of scoliosis for us. It was a paper where they just looked at girls who had scoliosis and said, who are the people who are going to progress and who are the people who are not going to progress? And what they found is if a curve is under 30 degrees by skeletal maturity, they're really unlikely to progress throughout the lifetime. This is not 100% true anymore, as we found out, and I'll talk about a little bit later. Osteoporosis definitely plays a role in progressing these curves later in life, but they won't progress as long as their bone quality is quite good. And in women who have curves over 45 degrees, these are expected to progress at about a degree per year. So this is actually a perfect example of this. This is a woman who's about 32 years old. And this is a patient of mine, and she was followed from 2010 when she had, I think, the last X-ray in our system. And you can see she has a 44-degree right-sided thoracic curve. This is a very typical curve for scoliosis. And then over the next 14 years, she developed about 12 degrees of progression, so on average around 1 degree per year. And it got to a point where she was family planning, wanted to maybe have a baby, didn't know a good time in her life to actually do the surgery. So decided to do the surgery before she was going to start having a family because, she thought that as soon as she had a baby, she'd be too busy to kind of ever get it done. And she knew that at that point, it would continue to progress by about a degree per year. So it was already in the operative area. And the reason is that, you could clearly see in that 56-degree curve that the vector of force on the top vertebrae, if you just see that line straight down where it says 56 degrees on that line is essentially the vector of gravity that's pulling on that vertebral body. And that's going to keep pulling down and down and down. So that curve is always going to progress because of gravity alone. So knowing that she elected to have surgery and she's quite happy with her results. Scoliosis during pregnancy, this is a really common question I hear. A lot of scoliosis we see is either untreated or already had surgery by the time women are deciding to have pregnancies. And it's important to kind of talk about this because I think that they have a lot of questions regarding it. So there are a lot of studies on this. Not a lot of them are actually high quality. So it might be an area where people have some more interest in looking at this. However, what they did find is people who have a diagnosis of scoliosis definitely have an increased rate of infertility. It's not that significantly different, but it is slightly higher. They obviously have an increased chance of having back pain, specifically during their pregnancy and following their pregnancy. There is increased risk of peripartum curve progression, and we'll talk about that a little bit more. But as you all know, there's a lot of ligamentous laxity that occurs as you get ready to deliver the baby, and there's obviously increased difficulty with epidurals because they don't have normal spinal anatomy, and it might be difficult to get that epidural in place. The interesting part of all of this is that there's actually no increase in having a C-section. This is a really common question. I will say there's a caveat to this. There are patients who require scoliosis corrections that end up requiring pelvic instrumentation, meaning screws that go from their spine into their pelvis, and it goes across the SI joints bilaterally. And in those cases, it's more likely that they're going to require a C-section because their pelvis is unable to open up naturally with ligamentous laxity because there are screws across the two major joints posteriorly. So importantly, kind of transitioning from scoliosis during pregnancy, but to spine health specifically during pregnancy. This is something that is really important. I see a number of patients probably every month who are pregnant, who may have back pain or something that's really debilitating them. And they're obviously pretty scared because managing that during their pregnancy can be quite difficult. So I always tell people maintaining a low impact exercise program, which is really focused on injury prevention. You really do not want to get injured while exercising during your pregnancy. So, it's not the time to be a hero and suddenly get in great shape, but it's time to kind of just maintain a low impact exercise program with resistance training. Maintaining core strength is really important. And obviously having good core strength prior to pregnancy is also very helpful. And the reason is that there are a lot of changes that happen to the woman's body during pregnancy. So on the top left, you see here, as the baby grows, you can see that the curves tend to increase. So you go from a standard, lumbar curve and a standard thoracic curve. And by the way, everybody already has different curve patterns. So there's actually like whole classifications as to the type of spine somebody has. So some people have very curvy spines, some people have very straight spines. So our idea of spinal alignment over the last 10 years has really dramatically changed of what's normal and what's not. But regardless of what their spinal anatomy looks like, their spinal changes, their alignment changes will occur, and it occurs in the sense that their lumbar spine will increase in lordosis, and because of that, there is a compensatory thoracic increase, and that's because of the added weight in the front that's essentially pulling on a lot of the muscular structures that essentially creates a large amount of lumbar lordosis. The other part of this that's important, as we talked about core strength, is obviously diastasis that can occur. And when you have a diastasis, your core strength is significantly weaker than it should be. And on top of it, you're having tons of added weight. As we know, during a pregnancy, a woman might be expected to, on average, gain about 25 to 35 pounds. And to put that into perspective, every pound you have on your body increases the weight across each disc in the lumbar spine by around 7 to 10 pounds. So you're talking about gaining somewhere between 250 to 350 pounds of increased load across the lumbar spine. So this is kind of like poor core strength, increased lumbar lordosis, a ligamentous laxity, tons of extra stress. And then you have the relaxin hormone. This is actually the chemical structure of relaxin. I thought that was kind of cool. And as you all know probably much more about this than I do, but it results in ligamentous laxity specifically around the pelvis, which plays a huge role in your spinal alignment and the stress load. And it can obviously increase your risk of having something like a disc herniation. So disc herniations are by far and away the most common thing you see during pregnancy as a spine issue. And unfortunately, we don't have a ton of options as to what we can offer some of these patients. Tylenol is by far and away the most common thing. There are medicines that we really can't offer, like muscle relaxers, gabapentins. Those things are pretty hard to offer, because of all the warnings about them during pregnancy. Physical therapy is definitely a mainstay of treatment. Even for most patients who are not pregnant, I always start with physical therapy and, anti-inflammatory medications. Unfortunately, Tylenol is not a great anti-inflammatory. It's actually not an anti-inflammatory at all, but it is a pretty good medicine at reducing pain. And then I have an asterisk next to oral steroids. I would love to hear the audience's thoughts about oral steroids during pregnancy. I know that it's kind of a controversial topic. Maybe it's not, but to my understanding, it is quite controversial as to whether or not we should be offering oral steroid packs, short 5-day doses to some pregnant patients. And then finally, there are two more invasive options. One would be obviously epidural steroid injections, which would help mitigate the risk to the fetus because it's not going to be, as systemically displaced in terms of the medicine. The benefit of ultrasound, obviously, is that you can use it and place it the same way you would do an epidural. The downside to this is usually if somebody has an obvious disc herniation that we see on an MRI, then we're actually trying to target that with more specific injections, like what we call transforaminal injections or selective nerve root blocks. And those require X-ray almost always. So those are unlikely to happen unless the patient elects to have a single X-ray image to make sure that the needle's in the right place. But more often, they're going to be getting more of these caudal epidural injections, which just flood the epidural space in the region. And these could be done the same way an epidural is done prior to delivery, just without the catheter. And then finally, in rare cases, surgical decompression can be offered, especially in patients who have neurologic deficits like severe weakness and or numbness that they don't want to have as permanent. We obviously are trying to push these patients late into the second trimester if possible, to obviously mitigate the risk of anesthesia. This was actually a picture from a paper that talked about a single X-ray being done, and you can see that they clearly put a lead apron over the belly to protect any radiation to the fetus. And then also you can see that they did their localization image one time, a single lateral X-ray, and they did 0 X-rays after that, because once they're in the right spot, they could obviously surgically find that disc herniation and take care of it, which is pretty awesome to see. There's also other ways of doing anesthesia nowadays where you can even do technically wide awake surgery, like microdiscs, small surgeries like that. Although we don't really do that at Cedars yet, we haven't really built an anesthesia program for that. There might be some of that coming in the future. And we're about halfway here, and we're going to transition to a whole different topic. So I just wanted to kind of open the forum for some questions. This is my baby, by the way, that was delivered here at Cedars, thanks to your guys' department. So thank you.
I have a question/answer for you. Thank you. This is a great talk and something we don't really hear. I'm Sarah Kilpatrick, one of the MFM docs in the chair. So your question about steroids. So from my perspective, oral steroids, short course, are fine in pregnancy. Prednisone doesn't really cross the placenta, so there's really not a fetal risk. And that what we worry about with steroids in pregnancy is long-term dosing, which increases mom's risk for gestational diabetes. So I would say, if you were seeing someone like that and you wanted to give her steroids, I would just reach out to her OB doc and say, this is what I'm doing. Let me know if it's a problem. You could phrase it that way. So, and we're very comfortable with that if it's needed.
Awesome. Yeah, thank you. I always bring it up, and I say I think you should always ask your OB first, just to make sure they're okay with it, because I'm not sure, obviously, their situation during pregnancy, what their health is like during their pregnancy. So putting that into rule, I would say I'll give you the prescription, but don't take it until you ask your OB.
Perfect. Yeah, that sounds perfect. And by the way, I love what you said about exercise. One of the worst things obstetricians have done over the years is tell women that when they're pregnant, don't exercise, it's not good for you. The reality is we have great data now that exercising actually reduces risk of adverse outcome in pregnancy. So love that.
Thank you. All right, so we will move on to postmenopausal bone health. So postmenopausal bone health is a huge part of spine care in the aging population of women. And to understand this, I just wanted to give a quick background on what bone health looks like. So this is going to take you back to maybe med school days, things that you've definitely put in the back of your brain and hopefully forgot. There are 3 major bone types. So the first we'll talk about is actually on the right side, osteoblasts. These are mesenchymal stem cell lineage. They're bone creating cells. So blast for bone forming. And then the exact opposite of that are osteoclasts. So I think of clasts as cleaning cells. These are actually hematopoietic stem cell lineage. So these are actually more like the immune system. So they're designed to basically clean the bone off. And you really need a good balance of both of these bones. And the balancing agent is the osteocytes, which are these mature bone cells, which are kind of within the bone itself. And they're the ones that send all the signals that say, we need more bone, we need less bone, we need more bone, etc. And the balance of both of these cells, blasts and clasts, is incredibly important to overall good bone health, because your bone is not a stagnant structure. It's consistently turning over. And the issue with osteoporosis is obviously that there's more bone turnover with not a lot of bone replacement. And then on top of that, the other really important concept within bone health to remember is something called Wolff's Law, which is force applied to a bone results in stronger bone. And this is actually an X-ray of two forearms of the same person, right and left. And this person plays tennis. And you could see that their dominant arm on the right has significantly denser bones in the forearm than on the left, which is their non-dominant arm. So you can see that just simply using your musculoskeletal structures more results in significantly stronger bone, because the bone adapts to the forces applied to it. So another quick background on this: bone mass or bone density peaks in the mid-20s. So I always tell patients, you're never going to increase your bone mass or density back to your peak, especially when I'm meeting them in their 40s, 50s, 60s. We're only basically trying to slow down their loss and essentially try to have their bone kind of regrow a little bit while minimizing their loss of bone. So overall, their density may kind of slowly increase, but it's unlikely to ever increase anywhere near their peak bone mass. And you can see why women are particularly burdened by this, because in general, women have lower body masses, and therefore they have lower stresses on their bones, and they never reach as peak of a bone mass as their male counterparts. And it's really important that early in life, people stay very active and healthy, because as they, if they have a good complex diet with tons of vitamins and nutrients, and then also exercise a lot with resistance training, and they're physically active, they're much more likely to have a much higher peak bone mass. And that's really, really important, because essentially you're going to lose your bone mass from that point on. From like the 30s on, it's downhill from there. And you can see that if you never get to a high peak bone mass, you're much more likely to have osteoporosis later in life. So this is something that needs to be caught much earlier with lifestyle changes rather than later. And osteoporosis, you could kind of see the difference in what healthy bone looks like versus osteoporosis, which is thinning of the cortical walls, that thick bony wall, and then obviously larger channels within the cancellous bone, which makes it a lot softer and spongier. So how does this play into a postmenopausal woman? It results in estrogen deficiency. And estrogen is a huge component of bone cell regulation. So it increases apoptosis of the osteocytes, which are those cells that basically are the mature ones that regulate the bone. And then it also increases apoptosis and oxidative stress on the osteoblasts, which are the bone building cells. And then unfortunately, it activates something called rank ligand, which is one of the primary modalities in which osteoclasts are activated, which results in much higher bone resorption than bone building, which results in osteoporosis. So really common causes of osteoporosis. These are some that maybe pertain to patients you're seeing regularly. Caucasian women of Northern European descent are higher risk than the average population, having lower body weights, getting premature menopause, of which we could talk about a little bit on the next slide or two, and estrogen receptor 1 deficiencies or polymorphisms. And then obviously patients who are on tons of these very common medications like SSRIs, furosemide, omeprazole, steroids, heparins. These are really common medications. So these are things to just be aware of. So postmenopausal spine health really starts with one major thing, which is exercise, exercise, exercise. There's no shortage of studies now about this. There are tons of studies that are reviews that kind of talk about what this is. There are tons of exercises that have been proposed, like this is the right exercise to do. Generally speaking, there is some benefit to resistance training. You don't necessarily need to be doing tons of cardio, but you do want to load the muscles in your upper and lower body. So there are obviously tons of, people like the Lift More program and this HIIT MEX program, but the reality is as long as patients are exercising and avoiding injury, which is a huge problem. I always say after I turn 30, like the only thing I care about with exercise is not getting injured, because an injury could set you back for a year or two. So all of those gains that you think you made will be lost very quickly, and much moreover with any small injury. So you don't want to be set back by that. And supplementation, this is something that needs to be happening earlier, not later. This is not a treatment for osteoporosis. This is a prevention of osteoporosis. So vitamin D supplementation, omega-3 supplementation, and calcium supplementation are all found to be quite helpful in prevention of osteoporosis. So having patients on this earlier while doing an exercise program is really important. And just to be aware, osteoporosis can definitely occur in younger women. So it's not just people who are over 50 years old or immediately postmenopausal. People who are BRCA1 and 2 gene carriers who undergo types of surgeries like salpingo-oophorectomies, they will obviously be forced into menopause with that type of procedure. And there's some studies that looked at this, and they basically found that people are very underscreened for this. So only 46% of patients were screened in this Canadian study. And then of that, they were screened at the age of 42. And they only had a 7-year follow-up, which is pretty poor considering that the average age of osteoporosis is 50, and the average age or lifespan of women in America right now is around 77 or close to 80 years old. So if you're losing them to follow up at around 49 years old or in the 50-year age range, you're really going to, just because they may not have osteoporosis at that age, they're very likely going to develop osteoporosis later in life. So early detection is critical for prevention of osteoporosis. It's really hard to take somebody with a T-score of -5 and get them to a sudden, like a T-score of -2, which is still osteoporosis. So it's much better to catch them when they're, in the osteopenia range or early osteoporosis range. So why does this all matter? This really matters because fragility fractures are by far and away one of the most common things that kill people. I think these seem very benign. So this is a compression fracture. It's by far and away the most common fragility fracture in the elderly population. And although this is in and of itself is a stable fracture pattern, almost never requires surgical intervention. We always kind of we get these consults, like basically I get like maybe 10 of these every week I'm on call. And we never offer any of these patients surgery, which is great. They get to avoid surgery. But the reality is there's a 5% increase in chance of having another compression fracture or spine fracture. There's a 2-time increase in having a hip fracture, which is a really debilitating fracture. And only 23% of these patients on average, if you look across the US, are getting sent to endocrinologists for bone health. By definition, if you have a compression fracture that is low energy and you fit the bill of being, over the age of 50 or sedentary lifestyle, you by all means have osteoporosis. You don't need a DEXA scan to tell you that. So these people should all be getting bone health consults. And on top of it, it's really important to know that the prognosis of these injuries, even though they're benign, is pretty bad. If you look at the mortality rate for compression fractures, 46% mortality rate at 3 years and 90% by 10 years. And that could be obviously a part of it that they're aging. They might be a little bit less mobile. They might have a sedentary lifestyle, which led to their osteoporosis. So there's a lot of confounding factors there. But it's really important to know that these patients are pretty high risk for losing their quality of life and maybe having a shortened lifespan. Treatment of compression fractures. There is some role in calcitonin for treating acute pain. It's not even a pain medication. What it does is it prevents the turnover of bone, and there's some thought behind that causing less inflammation, which then helps with the pain control. And then vertebroplasty and kyphoplasty, these are really reserved for patients, in my opinion, who are not able to ambulate whatsoever, which is quite rare. Most patients will be able to get out of bed with some pain medication regimen. And in rare cases, vertebroplasty, kyphoplasty, if they're still having significant pain around 4 to 6 weeks after the injury. You can see that these patients who are wearing this brace, obviously trying to look cool, and they're definitely not people with compression fractures. You can see even they are not happy people. These braces are really uncomfortable, generally speaking. So I always offer them. They're not mandatory for compression fractures. They're purely there for comfort. So if a patient finds them to be uncomfortable, they do not have to wear them. It's something that's just kind of there for them. If they find that the support is great, then that's great. If they find it to be cumbersome and annoying, I always tell them, feel free to take them off. And then osteoporosis plays a huge role in spine health. These are the three most common types of deformity we see in the adult population. The one on the left is called adult idiopathic scoliosis, which is similar to adolescent idiopathic scoliosis. It's essentially untreated adolescent idiopathic scoliosis, which you can see the curves could be pretty impressive. Degenerative scoliosis, which is arthritis resulting in small curves. And then sagittal imbalance or kyphosis, which you can see here. This is a patient that has severe osteoporosis and had multiple spine procedures and has severe kyphosis now because of their poor bone quality and obvious spinal malalignment. So it really plays a role in their health, but also it plays a role in their treatment. So this is a patient that I had actually recently who had an L5 burst fracture, low energy mechanism. And unfortunately, this is not a compression fracture. This is also kind of why I wanted to show it to you. This bone, you can see, is not just flatter than normal, but also it's front to back a little bit wider. So what ended up happening is a piece of bone from the back ended up in the spinal canal and caused her nerve root to be pinched. And she had dense numbness in her leg and was unable to walk because of the pain in her back, but also because she had weakness of the right leg. So we tried to do something small. We placed, a few screws above and below and did a fusion and decompressed her nerve. And the picture to the picture in the center is her intraoperative film showing that the screws were where they were. And then 2 days later, she gets out of bed and her bone quality, I remember putting these screws in and just, trying to have a quick prayer to see if they would stay. And her bone quality is so poor that the moment she stood up, even wearing a brace, her screws ripped out of the top of her construct because her bone continued to collapse over the screws. And those screws kind of stayed locked in the same place they were, and they kind of pulled out into her L3-4 disc space. So in order to fix this, we no longer rely on her bone, which has betrayed us. And we use cement augmentation, which is, filling the bone with really strong cement. And this allows the screws to have better purchase. Think of these kind of as like wall anchors for screws. If you're putting screws into like drywall, you really would rather put them into a cement wall so that way the screw doesn't loosen over time. This is essentially what we did, and we also use pelvic fixation. This is the pelvic fixation I talked about during pregnancy that may result in higher levels of C-section because these patients are not going to be able to open their pelvis the same way through their SI joints. And then assessing bone health is really important. DEXA bone density scans. These are interesting. DEXAs are basically the standard of care here in America for checking bone health and screening. DEXA scans are kind of crappy studies. Hate to say that, but it's true. It really depends on the machine, the technique, the calibration of that machine, the area of interest of what you're imaging. Commonly, if we order a DEXA here at Cedars, we're getting lumbar spine and bilateral hips. But some places they look at the distal radius, which is also found to be a pretty accurate way of looking at this. And it's important because a lot of people have hip replacements as they get older. So you're not going to accurately predict the hip bone quality. And then also you may have a lot of arthritis in your lumbar spine. So that's also going to get in the way of your actual accurate assessment. So some people may have very high T-scores based on their lumbar spine, but that's just because they have tons of arthritis and, end plate changes. So it's not necessarily the greatest. There are other ways of looking at bone health, looking at CT scans and measuring Hounsfield units of cancellous bone in certain areas is helpful. But ultimately, when we do DEXAs, we really care about the T-score. The T-score is basically looking at normal bone health compared to where you are today. And anything below minus 2.0 is by definition is osteoporosis. So there are a lot of treatments for osteoporosis, like tons and tons of treatments. We can kind of narrow them down to like major categories / categories of interest. Hormonal replacement therapy for patients who are candidates for that is not a bad idea. Recombinant parathyroid hormone analogs and romosozumab are the two medications that result in increased bone building. So these are anabolic agents. So not that they're diminishing the amount of bone you're losing, they're actually helping regrow bone, which is really important, especially in more severe osteoporosis. And there's actually a paper that came out of a place where I did my fellowship, and I was part of the collection of data for this study. It looked at patients who had osteoporosis, osteopenia, and regular bone quality prior to having long fusion surgeries for scoliosis. And what they found is the patients who had osteoporosis were all put on Forteo, and every single one of those patients did better than the osteopenia group, because the osteopenia group they were on no medications. So they were more likely to have mechanical failure. So Forteo put patients with osteoporosis in the same category as normal bone density patients for outcomes from mechanical failure standpoint. So Forteo is an incredibly strong drug, and it's definitely that class of drugs is definitely the medication of preference if a patient's going to undergo any spine surgical procedure. And then a lot less interesting to us is, bisphosphonates and denosumab, like Prolia. Those medications are really designed to minimize bone loss, but they really don't do much to improve bone quality. So they're not going to help us a ton when we talk about spine surgery or orthopedic surgery in general. And then finally, take-home points. Women are definitely more affected by a lot of spinal conditions than men. Pregnancy predisposes women to temporary, sometimes not temporary spine issues. It could definitely progress issues they already have. Many could avoid surgery at young ages, but will require surgical intervention later in life. That specifically goes for those spondylolisthesis cases or scoliosis cases. And really, I think the main take-home point here is bone health is critical for the longevity. It's really not something. I think we always talk about orthopedic surgeons as like, oh, they really care about the bones and like that's really all they care about. But I think we're finding more and more that your musculoskeletal health is incredibly important for longevity and maintaining a high quality of life. This is my final thank you. My baby, again, was delivered by the OB-GYN department here, so I couldn't thank you guys enough.
So thank you so much. That was a really, like I said before, a great talk. I do have one question, and it's going to be a ignorant question, but the picture that you showed in the first third of your talk, where you had the final of the three pictures, the final picture was where the spine had been corrected, and you could see all the hardware in there. And when I looked at that picture, my question is, wow, doing that surgery, that's all done in one surgery. I mean, it looks, the thought of like making that curve, yeah, this one, making that curve go like this in one surgery seems like that would be just crazy strain on existing spinal cord / bone. So that's my ignorant question.
Oh yeah, this is actually what I would consider a very mild operative curve because it barely fits the criteria. So we actually do much, much, much larger curves. Those are the ones where we worry a lot about spinal cord manipulation. In some cases, patients with certain types of scoliosis that are maybe atypical, like left-sided curves, because they're very typically right-sided. There are some red flags that we look for, like hyperreflexia, that maybe tells us the spinal cord may be tethered or something is causing spinal cord irritation. Those patients are much higher risk for any manipulation. So we obviously counsel them and maybe do even certain procedures to like detether their spinal cord prior to having that. But the grand majority of idiopathic scoliosis is quite safe to correct. This surgery took about 2 hours, and she was walking the next day, and she was out of the hospital the day after that. So, and if we do them in younger kids, some of them stay, a day or two. The complication rate of this is very low. There are some long-term implications, like the discs above and below are definitely seeing more stress because there's not a lot of mobile discs in between there. So, who knows what she's going to need when she's 60, 70 years old. But I always tell people, especially if they get into their adult ages without having had their scoliosis already corrected, that they have to tell me that they want the surgery. Like it has to be something that you really want, because obviously it's a big surgery. There are complications to it. And, you really have to say, this is getting in the way of my life for this reason, and I want to take care of it now. But we could definitively tell this patient, even in her 30s, that she's very unlikely to avoid surgery in her life, because if you take a 56-degree curve and she's 30 years old, by the time she's 60 years old, she's going to have, an 86-degree curve.
Yeah.
And that's a big, big curve to fix. And that's much higher risk. And she's going to be much older to be able to kind of, recover from that.
And is the pain management post-op difficult on these patients?
Everyone's a little bit different. I will say that it's not bad. I mean, oddly enough, I just actually did a much bigger surgery than this on an 80-year-old woman, and she was up and walking the next day. But then I've done this surgery on 50-year-olds, and they're like laying in bed for 4 days in agony. So I do think that there might be actually some muscular component to it. Patients who are very muscular tend to have more pain. I think they get a lot of muscular spasm from the dissection. So yeah, pain management, it can be an issue, but we usually have pain service in the hospital help us with these patients, and we usually get them off narcotics very quickly, usually within a month or two.
Great. Thank you.
Dr. Mikhail, it looks like there's a question in the chat. What is the status of the agents injected between vertebrae to relieve compression?
So is that a question about like injecting into the disc space?
That's what I was thinking.
Okay.
The person wants to elaborate.
Yeah, there's essentially there is nothing out there right now that fixes discs. We actually have one of the most funded disc regeneration labs at Cedars. We have a PhD who full-time dedicated to it and has like endless amount of grant money for it. And he has given us updates regularly, and there is essentially not a lot out there. They did some studies on, stem cell therapy and injections. Those studies did not go well. They actually compared them to, sham trials where they basically randomized people with stem cell injection versus saline, and they actually found that the saline group did better, which is kind of crazy. So then people started studying, is saline maybe something we should be injecting? And obviously didn't work very well. So where we're at now is there's nothing really that's going to increase the height of the disc besides, disc replacements and or fusions, mechanical devices that go in there that are not natural to the human body. That's obviously suboptimal, but I do think that if we could figure out, disc health, we would be putting a lot of spine surgery by the wayside, which would be awesome to see.
I had a comment and a question. So one, I really appreciate that you tailored the talk to our audience. I think you did an excellent job. So I'm sure that took extra time.
Thank you.
But a lot of it, I think, is relevant to, I do gyn-onc, so, I have the BRCA part and then pregnancy and things like that. So I just want to commend you on that. And then I guess sort of two related questions. So in general, is there, because clearly PCPs manage, osteopenia, osteoporosis screening to some degree. You had mentioned endocrinology. Are there certain people for like either patients who are particularly high risk or maybe have osteopenia, like either specific providers, who like really like doing this part, or are there any like prehab programs either at Cedars or in the community you might recommend to the providers here?
Yeah, so there is actually a specific endocrinologist here at Cedars, and her last name is Khosravi, Khosravi. Her first name is very long; it's like Azimut, but she is so busy because I think every single orthopedic and spine surgeon sends every patient to her.
Yeah.
And so she actually is working on getting another partner, which the spot is already funded. So we're really excited to have her have help. But she's really, really good about getting certain patients on the right medications to optimize their ability to have surgeries and things like that. Because some of these medications are really hard to get patients on, even if they fit criteria. Like Forteo, I guess, is a very hard medication to get patients on. And she knows all about, the ins and outs of which medications are best for that patient, what maybe they have contraindications to, or what they've tolerated, haven't tolerated. So that's really important, I think. Most endocrinologists are able to do that. But I do think that obviously having somebody specifically focused on bone health is really, really valuable to an institution like this where we do a lot of, musculoskeletal disease. And then the other part of this, in terms of screening, I would say that, or I guess first prevention, there are physical therapy programs out there designed specifically to prevent osteoporosis or improve bone health. So that's primarily resistance type training. So they do a lot of like axial loading and strength training. So if a patient, seems like, let's say sarcopenic or like they're frail in some way, you could put them in just a therapy program to increase their muscle and bone mass. It doesn't necessarily have to be for pain or any specific complaint. And then finally, in terms of screening, I think that when in doubt, I would just send them for a DEXA. At this point, I think you could get a DEXA every 2 years if you're on Medicare, like just by default. So anybody who has Medicare could get DEXA scans every 2 years, and most private insurances will offer DEXA scans every 2 years. I think after the age of 50. So you could always just send them for a screening DEXA, kind of see where they're at, and then go from there.
Yeah, and I think one of our NPs in the Gyn-Onc clinic is actually she's getting a menopausal certification, so clearly some of this interlies with that. So I definitely think building in, I remember when Alana Cass was here and as a fellow, we did a study in terms of like, were people who were having risk-reducing saprophorectomy actually getting their DEXA scans? And as you can imagine, based on that one paper you showed, we weren't doing a good job. Part of it is they kind of like fall out of our clinic because now they've had their risk-reducing surgery. But I do think our counseling is really important to make sure that they know that that's just as important as all the other bothersome symptoms of menopause. And then to your point, yeah, clearly if we have someone in our clinic, which is what we're hoping to do, then she can even do more detailed counseling with more time. So thanks.
Awesome. That's a very cool program.
But I have one more final comment question. This is Jessica Chan. I'm one of the reproductive endocrinologists. So thank you. That was an amazing talk. Thank you so much. And actually you gave me a lot of good talking points for my really young elite athlete, late teens, early 20s, like gymnasts, ballerinas who have lost their periods because of their hypoestrogenic states. So I have to convince them to take hormones. What's your experience with like prior athletes who have kind of been hypoestrogenic, and what is their spine health look like later in life? Because they also do a lot of strength training and things like that to strengthen the bones. Like, I'm just looking for more talking points to convince these folks to like go on estrogen, but just curious about your experience. Yeah,
Unfortunately, it's really hard to fully put that picture together because I see essentially like only the adult population. And, it's interesting. I see a lot of women who are in their, 60s, 70s, even 80s. And almost all of them say like, oh, I was a really elite athlete or a gymnast or something at some point in their life. And they have some of the worst bone quality, which is impressive. It's interesting because it is a double-edged sword, right? Like you want them to exercise, you want them to have good strength. But I think once you get into like a hypoestrogenic state, most of those patients are a little bit malnourished or, underweight, a lot of them. And I think that making sure that they have a diet where they're supporting they're like fueling what they're doing, right? They're at probably a high caloric deficit. They're burning tons of calories. So being able to actually convince them to eat a diet that supports that is really important. I think that, I wouldn't necessarily tell them to stop exercising, but obviously maybe minimize the amount of stress they're putting on their body. It's really, really strenuous activity. I mean, I just got this Whoop band and like, it's amazing, like the feedback it gives you in terms of like how, some days you just need a rest. It tells you like, hey, you went really hard yesterday. And it's like, if I do like a long scoliosis case, like the next morning I wake up and it's like, you're a dead person. You should not do anything today, So it's interesting to get that feedback. So maybe even have to convince them to wear wearables that give them like, biometric analytics and like feedback on how much time they should be actually resting to optimize their performance, because they probably are interested in optimizing their performance. And then also, having a good enough diet to fuel what they're doing, I think is really critical for patients like that.
Thank you so much.
All right. Thank you so much, everybody. Really appreciate your time.
Have a nice day. Bye.